The next session is going to be a very important session. I am going to request Dr. Subhash Gupta, Consultant Surgical Gastroenterology, Apollo Group of Hospital, to please join us to chair this session. Along with that will be Mr. Ghavri, General Manager, Punjab and Sindh Bank, to chair this session. The speaker is going to be Dr. DrAnupam Sibal. And somebody will ask me, कि एक General Manager of a bank, how is he connected with a lecture given by Dr. DrAnupam Sibal? Please join us. Ghavri साहब ध्यान से सुनिएगा, मैंने आपको क्यों बिठाया है. The lecture is going to be on a successful decade of liver transplant in India. सबसे महंगा जो ऑपरेशन ट्रीटमेंट पूरे इंडिया में है वो लिवर ट्रांसप्लांट. और मैंने एक फाइनेंशियल आदमी को साथ में इसलिए बुलाया, बिठा रखा है कि वो शायद ध्यान से सुने. मे बी बाय द एंड ऑफ द टॉक ही मे कम आउट विद ए स्कीम, yes, if you need a liver transplant, my bank is offer you the loan. If that happens, that liver transplant in the country will increase. Dr. Anupam? I'm basically trying to say is if a bank starts offering loans to patients for liver transplant, I think a lot of people, lot of lives can be saved. Therefore, listen to him, come back with, if possible, see if this scheme can come or not. I remember in a press conference, his executive director said, yes, it is possible to come up with such schemes that we should be able to offer treatment loans to patients who do not have money, provided they can have a parallel, they can submit a parallel security. I hand it over to Dr. Subhash Gupta to introduce Dr. Anupam Sibal for the lecture.
Is very well known to everyone, but in 1997-98, when liver transplantation was not thought to be a viable treatment, he conceptualized the current very successful liver unit in DrSubhash Apollo hospitals, and he'll share with us today the long journey that we've had, and he'll take you through the ups and downs of this program. Sibal, please.
Thank you very much, Subhash. Mr. Ghavri, I'd like to thank the organizers for this invitation. Very good afternoon, friends. What I've been asked to do is to share our experience over the last decade, and this is really going to look at the first decade of successful liver transplantation in India. The first successful pediatric liver transplant in the world was performed in 1967. Most of these children died because of rejection, and it was only in 1978 with the availability of cyclosporine that the results improved. The 80s saw major developments with establishment of brain death criteria, setting up of liver transplant units in the West. And in the 90s came segmental transplantation, and with better immunosuppression in the form of FK506, there were significant improvements in survival. And then also there came this technique of auxiliary liver transplantation, and by 2000 multi-organ transplantation was well established. Now if we look at the indications for liver transplantation, we see that in children less than 2, the vast majority are due to cholestatic diseases, and biliary atresia, which is a congenital abnormality, is the commonest indication, followed by acute liver failure and metabolic. But when we look at children older than 2, while 43% of these children will require a liver transplant because of cholestatic illnesses, metabolic conditions become very important and are responsible for 27% in acute liver failure at 15%. The indications have evolved over the years and now include chronic liver failure, fulminant liver failure, malignancy when the tumor cannot be resected, and metabolic conditions where there is no liver failure but liver replacement prevents the extrahepatic complications such as neurotoxicity in Crigler-Najjar or cardiac problems in hypercholesterolemia. Over the last decade, several conditions have now become important indications, and these include progressive familial intrahepatic cholestasis, bile duct paucity, neonatal hemochromatosis. In certain areas of the world, OTC deficiency, which is a urea cycle defect, is an important indication. Crigler-Najjar syndrome, protein C, S antithrombin 3 deficiency, hypercholesterolemia, and hyperoxaluria. A multi-organ transplantation for short bowel syndrome, gastroschisis, and TPN-related liver disease is now well established. And if we look at the US database for less than 5 cases in 1990, there's been a significant increase. Similarly, liver-kidney transplantation is now well-established therapy for primary hyperoxaluria, autosomal recessive polycystic kidney disease, methylmalonic acidemia, and if we look at the numbers, they've also increased significantly over the last 20 years. The survival results are very gratifying, and if you look at survival figures at 5 years, and in children less than 5, it's 76%, in older children 85 to 80%, and this is the cumulative database from the United States and Canada. It was thought that young age places these children at a greater risk, but it has now been shown that that is no longer the case. And if you look at 10-year survivals in children less than 2 and in children 2 to 15, you notice here that the patient survival rate is the same, 75, 76, and graft survival rate, again, there is no difference. So younger children can be transplanted successfully now. We also now have 20-year data, and this is 20-year data published in 2002, so this is for transplants done in the early 80s, and you have 66% survival and 64% survival. But when we will look at the data, and there is a review going on for transplants that were done in the late 80s, 90s, then the survival figures are upwards of 70% at 20 years. There was a big concern about transplanting children that were very small, less than 6 months, and in this paper, in children less than 6 kilos, we have 2-year survival rate of 87%. So again, liver transplantation can be now successfully performed in very small children, and perhaps the greatest achievement in this field has been the establishment of neonatal liver transplant, and in this paper, 11 transplants in 10 patients with a median weight of 3.25 kilos, and at 15 days of age, these babies were transplanted. We have 5-year survival of 80%, so truly gratifying. When we first started talking about liver transplantation in early 1998, we were asked 3 questions. Is there a need? Why are we bothering with trying to establish a program? And even if we try establishing a program, will it be possible to run a program successfully? And why is it that we have to run a program in India? Now, if we look at the Western data of 2 babies or children per million population requiring a liver transplant each year, about 2,500 children will require a liver transplant in India every year. This is our data over 12 years, 2,700 children, and while we've had a large series of complex acute viral conditions and other hepatic illnesses, we have a significant proportion of children with neonatal cholestasis, with chronic liver disease and acute liver failure who required a liver transplant. And we found that 11% of our children satisfied internationally accepted criteria for liver transplant, of which the largest was neonatal cholestasis, followed by acute liver failure, cryptogenic cirrhosis, and a variety of metabolic conditions, especially Wilson's, malignancies, hepatoblastoma, hepatocellular carcinoma, Budd-Chiari syndrome, and 1 child with congenital hepatic fibrosis. So clearly there is a need. Well, it would be simple to send them abroad, just that it costs between 70 lakhs to 1.5 crores. And also there is this additional cost of travel and stay, and that one would have to wait for an extended period of time, because an Indian child would be the last priority because of the fact that the livers would first be offered to the native population. So clearly there was a need to establish a program in India. Well, we attempted the first liver transplant on 11th January 1998, and this was a cadaver, and we had to withdraw treatment after 6 days because the liver did not work. The first success came in November 98. The first successful liver transplant for fulminant hepatic failure was performed in 1999. 2002, we retransplanted a child who developed portal vein thrombosis. 2007, the first pediatric cadaver transplant was performed, and in 2008, we performed a liver transplant on the youngest baby at 6 months, 6 days. This is the first child we transplanted, Sanjay, 18-month-old baby from Kanchipuram who had a failed Kasai's procedure. He had acute rejection, peritonitis, bowel perforation. He underwent 5 laparotomies.